Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
Introduced the, if I've introduced a fourth before. I've had a third before, but not a fourth before. So Quinn Capers the fourth, and he has so many honors that I wouldn't begin to talk about the many honors that he's gotten for his transformational work as an interventional cardiologist, as well as a person who's uh, kind of actually rediversified Ohio State and its College of Medicine, all of its efforts. So he is, uh, uh, I guess, one of the greatest honors we have is that he's a Howard University graduate, finished there in 1987, and then, of course, has done such outstanding work after going to Emory and other places that he's become internationally renowned for many things, including his work in cardiology as well as his work in addressing and changing the concepts of diversity and how unconscious bias affects us in all fields of medicine. And so rather than going to a long litany of the many honors and awards, I would just say that we were very blessed to have Quinn Capers the fourth to talk to us about some of the issues in heart disease.
Well, thank you very much, Dr. Callender. It's truly, I thank you for those kind words. I feel blessed to have started my career at Howard. I feel blessed to be back here at Howard. And it's quite an honor to simply see you in the hallway, to see you in the cafeteria, and to see you at meetings as I do, and to have gotten this invitation to share a few thoughts with you and your group. It's so nice to be here with everybody this morning. I thought I would talk a little bit about, and we can be informal, just talk about heart disease. I suspect these will be things that you know, or maybe you've heard in part before, but I hope we can have kind of a robust Q&A after I share with you a few thoughts. So cardiovascular disease is a big umbrella term, and it includes a lot of things. Coronary artery disease, and we're going to focus on that. Heart attack. We'll talk about congestive heart failure, sudden cardiac death, strokes, aneurysms, peripheral arterial disease, or poor circulation. All of these fall under the umbrella of cardiovascular disease, which all taken together are still the #1 cause of death in this country. Cancer is close, but the umbrella of cardiovascular diseases is still #1. All too often, this is how we find out that somebody had heart disease, that we are at their funeral. Heart attacks can be sneaky. They can sneak up on you. You can be really ill with severe blockages in your arteries and not know it. So what is a heart attack? We'll start here with the basics. As you know, every organ in the body absolutely must get its blood flow. The blood provides all the things that the tissue needs to stay alive: the oxygen, the nutrients, the proteins, the fats, the calories. It's all from the blood. So if the blood is ever cut off, then that tissue rapidly is in trouble and can begin to die. So even though the pump that pumps this blood all over the body is the heart, well, the heart has its own circulation. So it's got to get blood flow too. And it gets this blood flow from these coronary arteries that sit right on the top of the heart, and they deliver blood to the heart muscle. These arteries can clog up. They clog up with material that we call plaque, well, not the plaque that's on your teeth, although there are some similarities. That plaque consists mostly of cholesterol that circulates in your blood, white blood cells, blood clot, and other things. And it can clog up the pipes, as we say. And this process takes years. And when I say years, I mean decades. So when we see somebody in the cath lab that has a severe blocked artery, that person is 50 years old. What we know is that that blockage began probably when they were 20 years old. So we're talking 30 years it takes for these blockages to slowly grow until they get to a really severe level. This is more of a close-up. So this is the artery. The yellow stuff represents the plaque. And what happens is this plaque grows and grows until one day a spot will rupture like a volcano. And then you'll develop a blood clot at that spot. When that happens, the heart muscle has a sudden cutoff of blood flow. You only have minutes before that heart muscle begins to die. The more heart muscle dies, the weaker the heart is left, and the more the heart muscle dies, the more likely the patient is to die. I see Mr. Buchanan has a question.
I'm only seeing your cover sheet on your slideshow.
Oh, you're not seeing my slides?
No,
Okay. Well, thank you. Thank you for letting me know that before I got too far here. Let me see. I thought I knew how to do this right. Thank you for letting me know that. Let's try that again. Are you able to see anything now?
yes,
Yes.
now,
Okay. All right. Thank you. So this cartoon here shows the artery sliced open so you can see what's going on. The yellow stuff here is the plaque that clogs up the artery that again takes years and years to develop to a severe level of blockage. A part of it will then rupture like a volcano and cause a chain reaction that results in a blood clot, and that blood clot is solid and cuts off the blood flow. And as I was saying, you have minutes when that happens before the heart muscle starts to die because of lack of blood flow. The larger the area of heart muscle that is dying, the more likely the patient is to die. And so we need to move as fast as possible when somebody's having a heart attack. I just wanted to show this to make the point that autopsies on children as young as 9 and 10 years old have shown the beginnings of these blockages. They're called fatty streaks. So this is the very early lesion in what we call coronary atherosclerosis. So, you know, as you all know, often, and it's probably to our detriment, people don't usually start caring about their health, start thinking, well, I better start getting healthy until they kind of get into their late 30s. But it will behoove you and your families, your children, your grandchildren to start healthy eating habits and healthy exercise habits, even while they're children, and seeing the doctor regularly. And this is just showing how out of control things have gotten. We've got children that are smoking cigarettes. And of course, cigarettes is one of the major risk factors for coronary artery disease. This is a cross-section of a human coronary artery showing you what it looks like. And this is years beyond the fatty streak level. This is the lumen where the blood flows inside the artery. And this is the layer that's up against the lumen. This layer here that you see me tracing is the outer layer called the adventitia. And all of that in between, the inner layer and outer layer should not be there. That is atherosclerosis, that's fatty material, that's lipid, white blood cells. And this is what happens over years. That plaque contains cholesterol, inflammatory cells, blood clots, particles from cigarette smoking, believe it or not, particles from air pollution. There's emerging data now that the air that we breathe in, particles from air pollution, from exhaust from automobiles, can actually trigger and accelerate atherosclerosis and heart disease. It's a major killer. And along these coronary arteries, you can have several spots where you develop these blockages. And medications do a good job now. We have good medications to slow the disease process. But this is one of those diseases where there is no cure, but we can slow it down with good medication and good care. Until 1977, there was only one treatment, only one way to treat this disease when it got severe enough that the medicines didn't work, and that was open heart surgery, where our surgical colleagues, with their outstanding skills, would actually open the chest, and they reach inside your chest and actually do bypass surgery, where they create a detour around the blockage. That's what we call it, bypass surgery. I said until 1977. So what happened in 1977? Well, this guy came along. His name is Andreas Grunzig, and he was in Zurich, Switzerland, when he invented coronary balloon angioplasty, a way to open blocked arteries without having to perform open heart surgery. And he invented a catheter that would be introduced into the circulation, often in the groin. Nowadays, we do it mostly through the wrist. Advance that catheter up to the heart, across the blockage. A deflated balloon will go across the blockage, and then once it's across the blockage, you would inflate the balloon, and that pushes all that blockage out of the way. That's called angioplasty. So coronary balloon angioplasty was invented in 1977. Now, what's important, I'm going to talk a little bit about the symptoms of a heart attack and how we have to move quickly. When you believe you might be having a heart attack, time is truly of the essence. And let me talk about how heart attacks are treated. First of all, I always enjoy having the opportunity to talk to individuals and let them know if you have chest discomfort that frightens you, that makes you think you might be having a heart attack, please do not drive yourself to the emergency room. If it truly is a heart attack, one of the things the heart does when it's not getting enough blood flow is it'll just stop. If you're driving and that happens, that's bad news. If your neighbor is driving you or your spouse is driving you and suddenly you slump over, that's bad news. Because now what are they going to do? Are they going to keep driving? Are they going to stop the car, pull you out and do CPR? If you feel like you may be having a heart attack, let the professionals do it. Please call 911. They'll get you here as soon as possible. They don't have to stop at the red lights. They don't have to stop at the stop signs. And if your heart stops, they've got everything they need to get your heart going again. When you get to the hospital, the first thing we do is give you aspirin. So if you've ever heard that aspirin not only can prevent heart attacks in some cases, but treats heart attacks, and you had some doubts about that because that didn't sound quite right, that's absolutely true. That's number one. It's the first thing we do when a heart attack patient comes into the emergency room is to give them an aspirin. Aspirin is a blood thinner, and it begins to thin the blood, and in some cases can already open the coronary artery before we even get the patient to the cath lab. This is me and some of my trainees when I was at UC Southwestern before I came to here at Howard, and we're just having fun taking this picture, but we were there to treat a heart attack patient, and we're saying to the heart attack, you're in trouble now, because me and my boys are here, and we're gonna treat this heart attack. What we do is we take that tube, a catheter, we insert it into the circulation, either in the femoral artery. You can do it through the brachial artery. Most of the times now we do it through the radial artery in the wrist. We advance that catheter up to the heart, take pictures, and we find the blockage. And once we do, we inflate that balloon in the blockage, and instantly blood flow is restored. And it's a beautiful thing. The patient's pain goes away, the EKG normalizes, the vital signs normalize, the heart attack is over. It's something that I say to those patients. The balloon comes out. So we go in with the balloon, inflate the balloon to open the blockage. The balloon comes out. Then we go in with another balloon that has collapsed on it, a stent, a little metal coil, and we inflate that balloon and implant the stent. This is made of stainless steel, and that stent stays in. And as you see, it serves as a scaffold to keep the artery open. Here is an image of the left anterior descending coronary artery. It's been nicknamed the Widowmaker because it is, of your three coronary arteries, it is the most important, meaning that it supplies the largest amount of heart muscle. And a heart attack in this artery can often lead to death. That's why I got the nickname the Widowmaker. You can see in this angiogram where this left anterior descending artery is severely pinched right here. That's the blockage. This is before, and this is after. We've opened that up with a balloon and stent, and this is something that we really enjoy doing. When I was at Ohio State, I would always say to the patient after the procedure, this heart attack is over. My cath lab staff got a kick out of that, and so they got me these T-shirts, and that kind of became our motto. When we see a heart attack patient, we couldn't wait to tell them this heart attack is over. Risk factors are very important things about each and every one of us. And when we talk about risk factors for heart disease, they are medical facts about you that put you at risk for a heart attack. And we can count them up. And the more you have, the higher your risk. These are the risk factors for coronary artery disease or heart attack: having uncontrolled high blood pressure, uncontrolled diabetes, uncontrolled high cholesterol, smoking cigarettes, having a family history of heart disease, physical inactivity, and advanced age. And what I want to say about these risk factors is this. The good news is that most of them are what we call modifiable, meaning you can do something about it. That's why I was stressing when I listed them untreated. Because if you have high blood pressure, if it's treated, your risk goes down. If you have diabetes, if it's treated, your risk goes down. The same with high cholesterol. If you smoke cigarettes, we know how to treat that. Stop smoking, your risk goes down. Physical inactivity. What's the antidote for physical inactivity? You got to get active. And physical activity is defined as somebody who does not do the following, and that is do some kind of exercise that gets your heart rate up and keeps it up for 30 minutes. And do that at least 3 days a week. If you're not doing that, then you are referred to as having a sedentary lifestyle. So whether that's tennis, walking, swimming, jump rope, whatever you want to do that gets your heart rate up, not up and then down and then up and then down, but gets it up and keeps it up for 30 minutes, do that at least 3 days a week. And then you will have controlled that risk factor. So most of them are modifiable, but there are a few that are not. And those are the ones showed here in the small font. So hopefully we're all blessed to live an advanced age. That's a risk factor for heart disease. That one, there's nothing we can do about. We don't have an anti-aging process just yet. And a family history, right? We can't choose our family. So if your mother had heart disease and your father had heart disease and your grandparents had heart disease and your siblings have heart disease and you're born in that family, it could very well be that there's something in your genes that puts you at risk for having heart disease. But look at all the others that are in bold. That means even if you have a family history, if you control these others, you're able to modify and reduce your risk. So I hope that none of us on this call, including me, will have a heart attack. Maybe some of you have had a heart attack before. What I want to walk you through now is some things that will happen if you have a heart attack and you seek medical attention, so that if you happen to go through that, it won't be foreign to you. You will have heard it at least once. Or if you have a loved one who goes through it, you'll have heard it at least once. Remember that heart muscle begins to die because of lack of blood flow. And here are the main symptoms of heart attack. Chest discomfort. And I stress chest discomfort, where when I was a young pup right out of training, I used to always say chest pain. I'll tell you why I stopped asking patients if they're having chest pain. Because pain is subjective, and not everybody sees it as pain. And patients, they don't want to be ill. They don't want to think the worst. And sometimes, you know, we play this cat and mouse game. You got to be kind of a detective when you're questioning the patient to find out what's going on with them. Sometimes they'll deny their symptoms. And sometimes if you ask them a direct question, they'll answer that direct question and not tell you what's going on. I'll give you an example. When I was a young cardiologist, I had a patient that I would see. He had coronary artery disease. I would see him monthly because I was worried about him. And I would always ask him, Mr. Jones, are you having any chest pain? And he would say no. That was the end of the conversation. I came into work one day, and one of my colleagues told me, you know, that guy, your patient, Mr. Jones, he's over on the 3rd floor. He had a heart attack last night. Came in. So I went over to see him. And this is back in the days when there were paper charts. So I went over to the chart first. I looked at the chart, and his H&P said that he'd been having chest pain for weeks. So I go in and I talk to him, I make sure he's okay. Then I say, well, Mr. Jones, you know, I've been seeing you several times, and I always ask you if you have chest pain. And you would always tell me no. But on your chart here, it says that you've been having chest discomfort for weeks. He said, yeah, doc, you asked me if I was having chest pain. I wasn't having chest pain. I was having chest pressure. I was feeling like a pressure in my chest. So I learned a valuable lesson that day. And, you know, you would get a chuckle out of seeing me interview a patient now. I asked them, Are you having any chest pressure, squeezing, tightness, heaviness? Anything in this area that feels unusual to you? And I'm asking if you're having chest discomfort. So now I don't ask the direct question, are you having chest pain? I ask, are you having chest discomfort, or is there anything in your chest that doesn't feel right to you that you want to tell me about? Shortness of breath sometimes can occur without the chest discomfort. Sometimes profuse sweating. If you break out into a sweat and you don't know why, particularly if it's accompanied by chest discomfort or shortness of breath, that could be a sign of a heart attack. Abdominal pain. So the pain isn't always in your chest. Sometimes it's right above your stomach. We call it the epigastric area. Sometimes it's in the middle of your abdomen. Sometimes it's in your shoulders. Sometimes in your back. Sometimes in your throat. In fact, the term angina pectoris actually means a feeling that you're being strangled. In fact, I've seen patients that thought they were having a toothache, and what they were having was heart pain. It can cause nausea, but as we started off saying, sometimes the only hint is sudden death. So if you're having these symptoms, and if you don't usually have these symptoms, and you don't have an explanation for these symptoms, we want you to seek medical attention right away. Because remember that time is muscle. That's a saying that we have. And that means the longer that artery is closed, the more heart muscle dies. The more heart muscle dies, the more likely the patient is to die. And here it's really dramatic to think about the impact that time has on survival after a heart attack. When patients arrive to the hospital within 1 hour of onset of that chest pain, they have a greater than 90% chance of surviving. That goes down to 85% if it's 3 hours before they present, down to 80%. And you can see people that wait 24 hours, now they've got a 50-50 chance of surviving that heart attack. And you might think, well, who would do that? But let me tell you, a lot of people do that, right? Because again, none of us want to be sick. And so we're always thinking of something else that it could be. I've had many conversations with patients that go like this. Well, I had this discomfort in my chest, and I thought to myself, well, I did work out yesterday, so maybe I'm just sore in my muscles. So let me take some Tylenol. And then 3 hours later, the pain was still there. And I said, well, I did have a slice of pizza last night, so maybe this is indigestion. So let me take some Maalox. And I did that, and 3 hours later, I still had that discomfort. And I talked to my wife about it, and she said, well, maybe you just need to lie down. So I went and lay down, and I took a nap, and on and on and on. And then finally, 24 hours later, now they're really scared. Now they come into the hospital. Unfortunately, now a lot of heart muscle has been lost, and they are really facing a lowered survival. So 90% chance of survival versus 50% chance of survival. And it all has to do with how quickly you can get to the hospital. So we've got a job to do in terms of educating the public. So come to the hospital by ambulance. First thing they'll do when you say you have chest discomfort is do what we call an electrocardiogram. And I'll show you that this EKG, I'll just say that it shows that this patient is having a heart attack. So next stop, aspirin. We give that patient an aspirin tablet. We tell you to chew that aspirin tablet and get you right to the cath lab, where we take a catheter and advance it up to your artery, your heart, inject X-ray dye, and this is the artery. And you can see where that arrow, where it looks almost like this artery is disconnected. That's a very severe blockage. That's a 99% blockage. And that means that all of the heart muscle in this area is threatened until we get that artery open. The cardiac catheterization laboratory is a specialized operating room, and we gather our team and we work as quickly as we can to open that artery and put in a stent. And again, this is about the size of these coronary stents. They look like just what you see here, like a wire mesh. They're about the size of those little springs inside of a ballpoint pen. If you've ever taken apart a ballpoint pen and seen a little spring inside, that's about the size of these stents. So it's important that you know your risk factors. Remember those risk factors: high blood pressure, cholesterol, diabetes, family history, cigarette smoking, etc. Know your risk factors, because the more you have, the higher your risk. But remember the good news: your risk factors are controlled your risk is reduced. So that means know your numbers. What is your blood pressure? What is your cholesterol? What is your blood sugar? If you have diabetes, what is your A1C? And it's so important for you to partner with your doctor. You now know the symptoms of a heart attack, and you know that we treat heart attacks by opening those arteries as soon as possible. I want to talk to you now a little bit about another form of heart disease, and that's called congestive heart failure. Heart failure is a scary term. What it really means is the heart is unable to do its job properly because the heart muscle is weak. The heart's job is to pump blood all over the body. And when the heart gets weak, it's not able to pump the blood at a rate sufficient enough for your vital organs, your stomach, your brain, your kidneys, your liver, to get the nutrients that it needs, and fluid begins to back up because the heart isn't pushing it forward. And that fluid backs up, it backs up in the lungs, which can make you short of breath. That's the #1 symptom of heart failure. Or it can back up in your legs. Sometimes people will tell us that it backs up in the fingers. They'll say, my rings don't fit anymore. So swelling, edema can be, not always, because there can be other things that cause swelling, but it can be a sign of a weak heart and congestive heart failure. And this is showing you this diagram, the difference between a normal size heart and a heart that is enlarged with very thick heart muscle. And this X-ray shows you a very large heart. The heart, if you're not used to looking at X-rays, the heart is not supposed to be this big. So these are the patient's ribs. This heart shadow, we call it, is supposed to be about 1/2 of what it is. So this big basketball-shaped heart is much too large. This is a heart that is enlarged and weak, and this patient likely is suffering symptoms of congestive heart failure. The symptoms are shortness of breath, difficulty breathing, especially while lying flat. It's important to pay attention to that. If, when you go to bed, one of the things that we ask our patients with heart failure, or people that we think might be at risk for heart failure, is we ask them this question: do you have any difficulty sleeping flat? Do you sleep propped up on pillows? How many? Because this is an insidious disease that could sneak up on you, and it's human nature that what we all do when we develop symptoms is we adjust to those symptoms. So if somebody finds that they're short of breath when they're lying flat, then they just take a pillow and put it behind their head. And if that's not enough, they'll take 2 pillows, put it behind their head. Then they'll take 3 pillows and put it behind their head. But that's a sign that they are suffering perhaps from congestive heart failure. Swelling, especially in the legs, but also in the fingers, and it can be in the abdomen. And unusual fatigue. Like if you notice that you used to be able to climb a flight of stairs with only a little bit of shortness of breath, now climbing a flight of stairs really wears you out. That can be a symptom of congestive heart failure. The good news is that we've got wonderful treatments for congestive heart failure. We've got medications. And one thing I'll tell you is that the body is marvelous, and you know this. But a lot of diseases that we treat, what we're treating is the fact that the body is overdoing it in its compensatory mechanism. So the body has all kinds of ways to keep us healthy and to react to injuries, but sometimes the body goes too far. The best example of that, or a good example of that, I think, is asthma. So our lungs are supposed to, oh, yes. Does somebody have a question? No? Okay. So our lungs are supposed to, when you breathe in something that can make you sick, your airways are supposed to clamp down and secrete mucus to trap that stuff, and then you cough it out. But in somebody who has asthma, the body overdoes it, and it's doing that all the time, and all the airways clamp down, and they all secrete too much mucus, and they all cause a lot of coughing. So it's the body's regular compensatory mechanism that goes too far. In congestive heart failure, when your heart muscle is weak and your blood pressure gets low, your body secretes a lot of hormones to compensate. Hormones that make your heart beat faster, because that will improve your cardiac function. That makes your heart beat with more force. The adrenaline does that, or those are catecholamines. That causes your arteries to clamp down. to preserve the blood flow to your vital organs, your brain, heart, and kidney. And these things in the short term are helpful, but in the long term, they're harmful. That constant flogging of your heart by adrenaline or catecholamines can actually cause heart muscle damage and cause heart muscle arrhythmias. That constant clamping down on the arteries puts more pressure against the heart and makes the heart have to work harder. And it also, you secrete hormones to make your body hold on to fluid, which is a good thing in the short term if your blood pressure is low. If your blood pressure is low, you don't want to be urinating out all your fluid. You want to hold on to that fluid to keep your blood pressure up. In the short term, a good idea. In the long term, holding on to all that fluid finds its way into your lungs and into your legs and can be a bad thing. So these hormones that get activated when the heart muscle is weak help in the short term, but in the long term cause damage. And that really is the cornerstone of how we treat heart failure now. We've learned that if we block those hormones, if we block the catecholamines or adrenaline, if we block the hormones that make you hold on to fluid, if we block the hormones that cause your arteries to clamp down, we found that patients with heart failure live longer. It actually improves survival when we block those hormones. So that is the cornerstone now of how we treat systolic congestive heart failure. There's a new class of medicines called the sodium glucose cotransporter 2 inhibitors, which are really, they're rewriting how we think about heart failure. They're wonder drugs, and they're a good example of what you are probably aware of happens from time to time in medicine, that a medicine is invented with one disorder in mind, and the physicians and scientists do a clinical trial of that, and they find out that it's actually better at this other thing. You may or may not know the history of Viagra. Viagra was originally invented as a blood pressure drug. It was to treat high blood pressure. And the story goes that in the clinical trials, they gave out the pills of Viagra, and then they measured blood pressure, a few months out, and it didn't appear to be working as much as they thought. So what they do in a clinical trial is they then collect the medicine. So they called all the patients and said, okay, the trial is over. We need you to hand back in that medicine. And they noticed that the men didn't want to hand in the medicine. And then they found out why. One of the men told them why. So then, of course, the manufacturer said, oh, they saw dollar signs. They say, hey, we can do something with this. Well, these sodium glucose cotransporter 2 inhibitors are similar. It was invented as an anti-diabetes drug, a drug to help control blood sugar. So they gave it to all of these diabetics, and what they found was those diabetics that had heart failure were doing better. They weren't going into the hospital with heart failure anymore. They were breathing better. Their heart failure was improved. So dollar signs in the eyes, and I don't blame them. They have retooled it and started to specifically study heart failure. And we have found that this class of drugs, we call them the SGLT2 inhibitors or the flozins, they are remarkably effective in patients with heart failure, not just symptoms, not just keeping heart failure patients out of the hospital, but survival. Patients with heart failure live longer when they're on these drugs. So we call these now the 4 pillars of treatment of heart failure. The 3 classes of drugs that attack those hormones that are out of control, and these SGLT2I inhibitors. We also will usually treat patients with diuretics because they can have excess fluid. But those are medications. The other things we can do with our heart failure patients, there is no heart condition that is not made better with exercise, whether it's coronary artery disease, whether you've had a stroke, whether you have peripheral artery disease or poor circulation, whether it's congestive heart failure. Exercise that you can tolerate is always good. And again, aerobic exercise, something that increases the heart rate and keeps it up for a time, but also resistance exercise, weightlifting, increasing the muscle mass can actually improve cardiac function in heart failure, and it can prevent frailty. We all will tend to get frail as we get older, And it's an important thing to fight off frailty as much as you can, because when you get frail, that's when you are at risk for falling. And as you all probably know, once you fall and break a hip or break something, it can kind of lead to a dangerous spiral regarding your health and your independence. So lifting weights can kind of keep frailty at bay. Diet is very important in heart failure. Eating a healthy, low-fat diet and avoiding excess sodium. Where sodium goes, fluid goes. So if a patient with congestive heart failure who already has a problem with excess fluid in their body has a salty meal, that salty meal causes even more fluid to be retained. And again, that fluid can wind up in the lungs, wind up in the legs. One thing I noticed when I was an internal medicine resident, that doing the cardiology service, that after during the right after Thanksgiving break every year, you could set your watch to it. Every year, if I was on service around Thanksgiving break, that Sunday after Thanksgiving, the emergency rooms are full of people having an exacerbation of congestive heart failure, because Thanksgiving, families around, people go off of their healthy diet around Thanksgiving, they eat a lot of salty food, and then on Sunday, they wind up in the emergency room. So diet is very important, and of course, access to high quality medical care. So please share this with your loved ones. The American Heart Association recommends that you do some form of activity that gets your heart rate up. And for most of us, that's a brisk walk. And brisk can be as brisk as you can go. 30 minutes a day, if you can. If you can't walk, then get to a pool and walk in the pool. If you can't do that, swim. If you can't do that, do an exercise bike, something that gets that heart rate up. What exercise does is it actually, almost like a drug, it lowers the cholesterol, it lowers the blood pressure, it can keep your arteries clean, it helps maintain a normal weight, and it helps maintain normal blood sugar. So, healthy diet, exercise, and see your doctors regularly. I'm going to finish with something that's really important to me, and Dr. Callender alluded to this. I am one of my missions in my career has been to do what I can, work with others to do what we can to eliminate racial healthcare disparities. It's still, I consider, an embarrassment of the healthcare system in the U.S. that we still have healthcare disparities that run right along racial lines, with Black, Hispanic, American Indian individuals getting overall a lower quality of care than white individuals. You know this because we're at Howard University, and there's no place for me to be with that as my interest other than Howard University, where people like Dr. Callender and others, legends at Howard University, have been working on this problem for decades and decades and decades. So I'm proud to be at Howard University, where we take healthcare disparities seriously, and Washington, D.C. And our reason for being is to combat these healthcare disparities and serve the underserved. But I want to say that automatic implantable cardioverter defibrillators, these defibrillators that are placed inside the chest, monitor the heart rhythm, and shock the heart when the heart stops. In fact, you might know that the first one was ever implanted in the human by a Black surgeon, Dr. Levi Watkins, not too far from here at Johns Hopkins University. Data shows that Black patients who survive a cardiac arrest are less likely to have an ICD implanted than white patients who survive a cardiac arrest. We've known that for 20 years, and that nationally has not gotten much better. When it comes to treating a heart attack and having that procedure I showed you, getting the cardiac catheterization and having the balloon angioplasty and stent to open up the arteries, recent data, as recent as last year, shows that in this country, Black people, Hispanic people, Asian people suffering from a heart attack are less likely to have that procedure than white people suffering from a heart attack. And then when it comes to poor circulation in the legs, peripheral arterial disease, the data has continually showed for more than 20 years that Hispanic and Black patients are less likely to have a procedure that restores blood flow to the legs and are more likely to have a limb amputation. This is today. I'm not talking about 10 years ago, 20 years ago, 50 years ago. Today, this is what's happening in our country, which is why Howard's legacy is so important and our present is so important, because we are producing the doctors that will go out and combat these disparities. I just wanted to show you that one of the first papers documenting the fact that Blacks are less likely to be treated appropriately than whites with a heart attack was in 1993. Most recent paper was just a couple of years ago in 2022. So that's 4 decades of research showing these disparities. This isn't a problem that's being hidden. It's not being hidden. We're writing about it. We're writing about it. We're lecturing about it in the academy, but nothing is changing. We did a review article on this a few years ago, and what we found is that in a 30-year period, no fewer than 300 papers were published showing these racial healthcare disparities, and this is just in cardiology. We're not talking about cancer. We're not talking about transplant medicine. We're not talking about diabetes. This is just in cardiology, 300 papers. But the sobering thing we found is that the disparities were just as bad at the end of that period where we had published 300 papers about the problem as it was at the beginning of that period. So publishing papers on the problem, describing the problem is important, but clearly that's not enough. And when I lecture to medical students, we come up with a list of things that can cause these disparities: racial bias, both unconscious and conscious, mistrust. Maybe the doctors caring for disadvantaged communities are underperforming. Maybe there are inadequate resources at the hospitals that Blacks tend to frequent. Maybe there are differences in health literacy. Maybe it's outright racism. Racism is not unconscious or implicit bias. Racism is conscious bias. Maybe it's these individual biases and structural societal biases like the social determinants of health. And maybe it's because there's a lack of racial diversity in cardiology. And that's something that I've spent a lot of my career trying to fight against. So I'll stop there. Thank you for giving me a few minutes this morning, and happy to hear any comments or take any questions.
Well, I'd personally like to say thank you again for the wonderful presentation. It's interesting in our, actually next year will be 50 years since we started this group. We've never had a cardiologist to present to us. And so we were particularly blessed and excited that you could take the time to do so in such a magnificent fashion. So thank you very much. And the floor is open. We'll start with Lucy Perez and then Darryl Armistead.
Thank you.
Outstanding. Outstanding. You have made a difference with your life, and I am so grateful for this opportunity. You are anointed. One of the things that I think is so important and so critical as we put Vice President Harris into the presidency is that we make sure that disparities in healthcare are top of the agenda as it relates to health. And it could have gone either way, either education or health at the time of the Board of Education and ending segregation. So again, thank you for this presentation, and I'll be praying for you.
Well, thank you very much. I can't tell you how much I appreciate that, and definitely appreciate the prayers. I will pray for you too.
Darryl, you're next.
Thank you, Dr. Capers. Outstanding presentation. I had a few questions. I saw on your scrubs it said interventional cardiologist. That's your specialty?
Yes, it is.
Okay. All right. The 3 types of catheterization points, groin, brachial artery, radial artery. Could you talk about the differences in recovery and downtime depending on the insertion point for the catheters?
Yes, yes, happy to, and thank you for that question. So all cardiologists were trained to do these procedures by puncturing the femoral artery in the groin and then advancing the catheter up to the heart. That has been the standard for so many years. When we do that, basically think about it, now there's a hole in the artery. So when we take out the tube or take out the catheter, we hold pressure and, the bleeding will stop. But when you are sitting up, you're actually kinking that femoral artery, and that can cause pressure and could cause it to bleed. And so the recovery after these heart cath procedures is that you need to remain flat for anywhere from 2 to 6 hours. A lot of people have trouble with that. So a lot of people have severe back pain. And I've seen many times patients are squirming and they're really uncomfortable. We got to give them pain medicine, and it's really hard for them to comply with that. As we just talked about, if you have congestive heart failure, then lying flat on your back for a couple of hours can be a tall order. And it's just uncomfortable. And because then when the patient gets up and walks around, something could be jostled loose. There were more complications when it's done from the femoral artery. Doctors have been doing it from a puncture in the brachial artery for quite some time, but actually that wound up having a lot of complications. And because you only have one brachial artery, it's a single artery that branches at the elbow. But if you get a problem here, if you get a blood clot here, or if that brachial artery closes off, now the whole arm from the elbow down to your hands is ischemic. The radial artery, we got a radial artery on one side of the wrist and the ulnar artery on the other. They're about the same size. And the good thing about it is in your hand, as you know, you have circulation. We call it a palmar arch that's supplied by both of these arteries. So if something happened to your radial artery and you still have an intact ulnar artery, it really is an asymptomatic event. And so we found that when we do these procedures from the radial artery, number one, the patients can get up right away. I mean, the instant we're done, you can sit up. So if you got a bad back, or if you got lung disease or heart disease, it makes it difficult to lie flat. That's important. The patients can be discharged sooner, and the rate of major vascular complications is much lower. So the standard today at most places is to do these procedures from the radial artery in the wrist, although we still do them from the femoral artery in the groin at times because, as you might imagine, the femoral artery is much larger. It's about the size of a Sharpie marker, whereas this one here in your wrist is about the size of the small straw that you use to stir coffee. And some of our devices, some of our catheters, we just need more size than we can get in the radial artery. So we still do some from the femoral artery, but the preferred approach now is to do it from the radial artery. It is safer, patients tolerate it better, and patients can go home sooner.
Thank you very much. And my last question, I've heard it said that coughing during a heart attack can be helpful. Is that a myth, or is there a fact basis with that?
So there is a factual basis to that. As I said before, one of the things that can happen during a heart attack is that your heart can stop. Sometimes that's from kind of an intense vagal reaction, an intense reaction of the nerves that control the heart, and it can cause the heart to stop for a long time. Coughing kind of breaks that cycle and can actually restart your heart again. So yes, there is something to that.
Thank you.
You're welcome. Thanks for the question.
John Buchanan, you're next.
Yes, thank you so much, Dr. Capers. That was an awesome presentation. I got something to say about that in a minute. But my first question is, you brought up the disparity in treatment based on race, especially for the heart. What can be done about that? What do you think are the ways that we need to address that disparity?
There's a long list of things we need to do because it's a multifactorial problem. And this is just the way I teach it to the students and the fellows. There are a lot of things that cause a problem, and there are a lot of potential solutions. So I'll just run through some of the potential solutions. My favorite, and what I've really made my focus of my career, is a more diverse physician workforce. So we need more Black cardiologists. We need more Black heart surgeons. We need more Black vascular surgeons because the data is in. They do a better job of taking care of patients that come from difficult circumstances, patients that come from disadvantaged communities and underserved communities. So that's a part of it. And right now, the numbers show cardiology is not very diverse at all. Not even 3% of cardiologists in the United States are African American. It's just 2.7%. Only 5% of cardiologists are Hispanic, and 17% of Americans are Hispanic, but only 5% of cardiologists are Hispanic. Even women, cardiology also has a woman problem. Only 13% of cardiologists are women. We're doing a little bit better than that in the training programs, but that's a problem. So we need a more diverse workforce, number one. Number two, we need I like the idea of algorithms, of protocol-driven care. I'll tell you, I've come I've done a 180 on that in my thinking. When I was a resident, the idea of protocols or pathways for care came out, meaning that if a patient had a certain disease, then these 3 things must be done, no matter what. Well, I didn't like that when I was a resident because I said, well, it should be up to the doctors. That should be up to the doctor's discretion. That might work for some patients, but not for all patients. Well, I've done a complete 180 now because I've seen too many times and too many studies where the Black patients did not get an angiogram. So the Black patients did not get a beta blocker. The Black patients did not get lipid-lowering therapy. So now I like the fact of saying, listen, this is the protocol. Your patient's diagnosis is heart attack. I don't care who they are. They have to get a beta blocker. They have to get a lipid-lowering therapy. They have to get aspirin. They have to get Plavix. You have to do an angiogram. Or you have to have a very good reason why you're not doing that, and you've got to document it. And that is tied to reimbursement to the hospital. So I think it takes things like that, protocols, it sounds odd to say, but where you're taking the discretion away from the doctor. Where I, as a doctor, I can't say, I'm going to give this patient with a weak heart a defibrillator, but not this patient. No, take that discretion away from the doctor. The patient has things that put them at risk for cardiac arrest, then you should be considering them for a defibrillator. So that's another thing. And another is, I think where you really get hospitals' attention is when you talk about accreditation. So when the Joint Commission on Accreditation of Hospitals, I really think that they need to incorporate more. They do some, but incorporate more of disparities in the accreditation of a hospital. So you're a hospital, you are doing all these things right. Let me take a look. Let me see what is the outcome of men who are diagnosed with heart failure and women who are diagnosed with heart failure. Those outcomes better look the same. Let me look at their survival of Blacks who were admitted with a heart attack and whites who were admitted with a heart attack. Those outcomes better look the same. If they're not, if they're discrepant, then that's going to be a mark on your accreditation. So I think there's some things that we can do that we haven't quite done yet or we haven't done enough of, but we're working on it.
Thank you so much. My last request, since we didn't get the first maybe couple of slides from your presentation, I think the structural diagrams you have might be helpful. I don't know if you want to go back to share those.
Well, I tell you what. How about I give those to Dr. Callender, and I'm happy to share them all with you.
Excellent. Okay. Thank you very much.
Jochebed, George, you're next.
Thank you very much. And thank you for that presentation. I missed the first few minutes of it, but my concern is I have been diagnosed as having atrial fib, and I had the cardioversion, electric cardioversion, and that helped a lot. But it seems like it's coming back, the fib, and I just wondered what is the best treatment for that?
Well, so thank you for the question. I'm glad it sounds like you're getting some good care. It was recognized that you have this arrhythmia, this heart rhythm problem called atrial fibrillation. One way to treat that, other than medicines, so you got to be on good medicines, but then having the cardioversion, an electric shock that'll jolt the heart back into a normal rhythm. Sometimes your heart can go right back into it, days, weeks, months, maybe years later. There are proper medications that you need to take, but there's another procedure that maybe you should discuss with your cardiologist, and that's called an ablation, which is a way to put a catheter, much like what we just discussed, into the groin, go up to the heart, and they can actually, inside your heart chamber, where the problem is these electrical wires are kind of all in disarray, and then they make the heart beat in this abnormal way. But they can, with a catheter, make some lines in the heart to disrupt that disarray beating and return it to normal function. That's called an ablation. So you may want to discuss that with your doctor.
Thank you.
You're welcome.
Darryl, you're next.
Yes, in your presentation, you were showing X-rays that indicated blockages of the arteries.
Yes.
Were those generated by MRI, CAT scans, or how are they generated?
Those were generated by what we call an invasive coronary angiogram, or the nickname for that we use is heart cath. And that's the procedure that we talked about, where we take that catheter and which is a long tube, and either insert it into the femoral artery in the groin or the radial artery in the wrist, go up to the heart. And we get the tube right outside the coronary artery, and then we inject X-ray dye. We inject that X-ray dye. So this is an invasive angiogram. Now, you just mentioned you can do a non-invasive angiogram. You can do it with a CAT scan. CT coronary angiography has really taken off, a way to see your arteries without having to do an invasive procedure. And there's even a way to do it with MRI as well. But those images I was showing you, those were invasive coronary angiograms. And if somebody's having a heart attack, we want to do that, because then we've got all of our equipment ready to go when we see that blocked artery, that we can go ahead and fix it.
Okay, and the reason why I mention that is that, part of wellness exams, physicals, it'd be great to have some type of scan just to see how you're doing, to see if you have any blockages, extent of blockages. And the invasive procedure, I understand why that's not going to be part of a regular physical, because it is invasive and it's more expensive. Is there any way of sneaking that CAT scan into a wellness exam?
Yes, depending on your doctor and depending on your insurer. So they're actually, once we started to learn that we can really get a good idea about the arteries from a CT scan, there actually was a meteoric rise in what's called CT coronary angiograms or coronary calcium scoring CT scans, just as a part of wellness visits. As you might imagine, as usually happens with our healthcare industry, once a lot of doctors start doing it, and the prices start going up, the insurance companies say, "Hey, wait a minute, what's going on here? We need to put some restrictions on this." So now you can still have your doctor order a CT coronary angiogram, but there are a list of indications for which your insurance company will pay for it. But about 10 years ago, your doctor could just do it and your insurance company would pay for it. Now, if your doctor does it and you don't have a good reason in the eyes of your insurance company won't pay for it, and you'll be stuck with a pretty big bill. But for people who have risk factors for heart disease, getting this screening CT scan for coronary artery calcium, it doesn't show us all the arteries, but it turns out if you have blockages, usually there's some calcium deposits in those blockages. And so a very quick CT scan that shows you have calcium in your coronary arteries is a sign that you do have some blockage in your arteries. And that actually can be paid for if your doctor uses that as a screening tool. So you can ask your doctor about coronary calcium screening CT scans, and if that's right for you.
Thank you.
Let me say, as much as I'm enjoying this, I've got another meeting I've got to go to right at 10, and you'll be happy to know that I'm interviewing candidates for our cardiology fellowship. So I'm working on getting us some more Black cardiologists. It's been a real pleasure being with you all. Thank you so much, Dr. Callender, for the invite. I'll get you these slides. thank you all so much. It made my day just spend a little time with you.
Thank you. Magnificent job. Thank you. Thank you very much. So we were very blessed to have the top of the line talking to us. As a matter of fact, I saw some new people that I hadn't seen before. Actually, I saw Fredette West, who I haven't seen in years, although she's not here anymore. But